Yeah. Dr. Tejasvi, my colleague, is going to present the case presentation.
Good morning, everyone. Our second case is a 24-year-old female of Takayasu arteritis. She's been a known case for the last 4 years and currently has no disease activity. She's on immunosuppression with prednisolone 5 mg once a day. ESR and C-reactive protein values have remained normal on follow-up. She is hypertensive on metoprolol and ramipril. She has had an MTP for severe fetal IUGR 8 months back. Her blood pressures in the right upper limb is 150/90 and there's close to 30 mmHg systolic BP difference between the upper limb and the lower limb. ECG and transthoracic echo were suggestive of concentric LVH with ejection fraction of 68%. Her CT aortogram in the thoracic aorta, as you can see, shows a narrowing quite distal to the origin of the left subclavian artery with a saccular aneurysm, and distal to that you can see a dissection flap. The cross-sectional area of the aorta cross-sectional area of the aorta was close to 19 into 17 centimeters, both proximally and distally, and the narrowest segment was measuring 10 into 13 millimeters. The whole length of the disease segment was quite long, around 87 millimeters. This is the CT aortogram of the abdominal aorta, where you can see that the right renal, there is a chronic total occlusion, and there is also another saccular aneurysm and dissection here, and the aorta is narrowed quite a lot, the narrowest segment measuring 6 into 4 millimeter, and then the distal normal aorta measures 12 into 12 millimeters. The left renal artery is normal and it originates just below the narrowest segment. This is an angiogram where again the narrowing, the saccular aneurysm is demonstrated. 5 months back, we did a right renal CTO recanalization and stenting of this right renal artery. And now currently she is admitted for addressing the thoracic aorta and abdominal aortic issues. For this patient also, with the help of Dr. Adam Kolesnik, we did a reconstruction using virtual reality, where the dissection flap and the narrowing and the aneurysm were quite well demonstrated. Using VR,
what was the size discrepancy this time?
The stent required was quite long, and the diameter measured around 16 to 18 millimeters. This is a reconstruction of the abdominal aorta, which shows quite well that origin of the left renal artery, which is originating below the starting of the narrowest segment. So our plan here is to address the thoracic aorta with stents, 2 overlapping Zephyr balloon expandable covered stents, and abdominal aorta using a bare Zephyr balloon expandable stent just below the right renal stent.
Shiva,
Okay.
I want to make sure that you Shiva, hang on. Listen to me. We have very short time because we have to go to Sidra relatively soon.
Okay.
So if you can expedite it, that'll be great.
Sure.
Now, Shaq, he was asking.
Show the angiogram. See, what we did today was, lateral view, show the thoracic. Yeah. So you can see that the pseudoaneurysm is overlapping on the aorta, and the aortic dimensions are around 16.5 proximally, 18 distally, with a length of 86 millimeter. I'll show the lateral view. So the lateral view shows that large pseudoaneurysm that is protruding. Freeze it when the aneurysm is shown. Yeah. So keep moving forward. So it is like a very multiloculated saccule in front. Again, we were having about 13 millimeter proximally, 14 distally with a length of 8 centimeter. Aortic aneurysm, abdominal aorta. As was mentioned earlier, this right renal artery was recanalized and we stented it about maybe less than 1 year when she had very refractory hypertension and a total occlusion of the right renal artery. So at that time, the aorta is around 12.6 proximally, 11 distally, and the narrowest portion is 6.3 with the length of around 45. Next, lateral view. In the lateral view, freeze it. Okay. Freeze and Okay. So again, the narrowest part is about 4.3. So our intention is to go to the first proximal lesion with a covered stent. This is a new cobalt chromium covered stent, which is similar to Andra but made in India. It's called Zephyr. The difference between Andra stent and this Zephyr is that there is a peculiar C and S link which prevents, which prevents foreshortening of the valve. So the length remains more or less static. It doesn't foreshorten. So now what we are planning to do is, since even this 79 is not able, will not be good enough to cover the entire length, we are planning to put in two stents overlapping with each other. The first stent will go proximal and leave behind some of the distal descending aortic dissection open. I'm finding it little tough to push it through a 12 sheath. It's very tight.
Use a bigger sheet.
Shiva, how's the covering on the stent? Is it glued on or stitched on or embedded?
No, it is totally welded. My colleague Dr. Fareen Qureshi will show you a bench tested stent. She will show you now. Show it. No, not so close. Be a bit, yeah. So this is the bench tested 25 millimeter. It's totally embedded. The method of making the stent is called sintering. Basically, they heat the stent to just below its melting point and allow the PTFE to fuse over the metal struts, the cobalt chromium metal struts.
No, that's why I was asking whether what the mechanism was, because you were trying very hard to remove the covering otherwise.
No, it doesn't go away like a CP stent shack. It is quite strong. The second thing about this stent is that there are no 8 centimeter balloons that we have of the size that I am using. It's a 18 millimeter balloon that I have chosen. I don't have a 8 centimeter balloon, so I am mounting on a 6 centimeter balloon, which means I'm going to have a distal unexpanded portion and the proximal unexpanded portion. Then I have to move the balloon and then get it fixed. Let me see whether I can. It's pretty tight.
Oh,
okay.
No, it's not. So I may need actually I thought of going gentle on the groin with a 12 French sheath, but now probably I may have to upsize it.
I told you to use a larger sheath, remember?
Zahid, the problem is it's being an artery, 14 French sheath. Or else give me a 13. Let me go a little. Cook 13 sheath. Being an artery, I was trying to be a little gentle on the artery, Zahid. $13? Sister, come here. Is that a 13 or a 14? 14, huh? Okay, give me 14. Zahid, I don't have a 13, and so we are going for a 14. Okay, give me open the 14. Open the 14.
That's what Zahid was saying. You should have done that in the first place.
I agree. Wise persons are sitting at Bangkok. We are left with only the remaining people outside the world. Length is not enough. What is the length? 45 may not reach. Let me try.
So Shiva, we need to hurry up because Qatar has been knocking on the door for a long time.
Understand.
And they are kind of not happy because their patient has been on the table for a long time. So if you could expedite this, I'll really appreciate that. We
Yeah.
all will. Do. Thank you.
The difference is now that this stent, the sheath is not large, but let me see how far it goes. Yeah, it's fair enough. Okay, hold it. In this lab, I have Vishnu and Ashok, my two colleagues who are one at the femoral end and one at the radial end. Ashok is ready with the radial axis angiogram SOS, and Vishnu was actually putting in all the catheters and wires. Uh, yeah. So, and in radiographer, I have Mohammed and Subin, and anesthetist is Dr. Arun, Dr. Giridhar. Dr. Uday is the head of the ICU team. He is also supervising. Keep it straight, ma.
Is it
No.
still tight? Even the
No,
wire is
actually, it's tight on the wire. So
tight. The sheath was tight, now the wire is tight.
okay,
What's
for
next?
holding.
That's because he was crimping the stent onto the balloon without a
Without the wire.
wire inside the guide wire lumen.
Okay, good. Shiva, I also want to say congratulations for these two cases. Congratulations to all your team on working on Sunday. We really, really appreciate that. Because
Okay,
I know
now
once you
can
do
you
this
pull
stent
the
inflation,
this one?
we have
Go to lateral view.
to Qatar, okay?
Go to lateral view, please. Pull it and get it into the aortic position.
So it looks as if your balloon is somehow shorter than the stent, right?
Yeah, balloon. But
Yes.
I mentioned that the balloon is 6 centimeter. Now pull
Okay,
the
thank you. Sorry, I missed that.
pull the pigtail up. Further, further, further. Yeah, make an angiogram at this point. Ready for injection. Move the table away from me so that I get the maximum view. Little bit more. IAO. Okay, again, drop the table. Drop. Drop. Okay. Collimate the site collimation. Yeah. Ready for injection? Shoot. Okay. See, the late filling structure is the aneurysm. Let me see whether I am. Yeah, I am okay on the proximal end. I will just move it a little bit up, and I will unsheath it.
Shiva, a technical question. How
Yeah.
how much for shortening of this stent?
I mentioned that this is a 0-4 shortening stent.
Sorry.
It's made up of a peculiar C and S link that doesn't foreshorten at all. Make another angiogram and then we should be ready to pull out the pigtail. You are ready? How much are you giving? 15 at 15 I want. 1.5 at 1.5. Ready? Yeah. Sister, you may have to tell me the number. This is a Z-Med balloon. Okay. Now pull out the pigtail up. Pull out. Little bit above. Just come above. Little bit above. Enough. Enough.
And also, do you want to move the sheath down a little bit as well?
Shaka, I'll show you. The balloon is well distal. I have only the stent there. You see that
Okay.
the balloon is far more.
Keep going though.
Yeah. So tell me the number, sister. Keep it pushed up, Vishnu. So we have reached about 4 atmospheres. So at this point, I will withdraw and I will push the balloon distal and get it fully opposed. Just to hold the wire. So I'm giving a proximal approximation. 4 atmospheres now. I'm fully deflating. I want pressures on the side arm. Show me the pressures. Quite hypotensive. Maybe my sheath is covering. No, it's quite hypotensive. Can you make just push the pigtail inside? Push it inside. Push it inside. Okay. Make another angiogram. Okay. Probably, see the proximal end, the distal end, I have to inflate because it's being a covered stent. At this point, I will inflate. This is the challenge of not having an 8 centimeter stent. I'll keep it there. 8 centimeter balloon. So I'm coming below. Okay. Okay. Now inject from the top. Inject from the top. Pressure is back. Shoot. Okay. Actually, I have covered the pseudoaneurysm, but there is a lower dissection flap. Come to AP view now. AP view. You are holding. Ashok, is it possible
Shiva,
that you can advance
show us very quickly, we gotta move on.
Yeah.
Shiva, we have to move on. So you have 30 more seconds, whatever you want to show us now.
Yeah.
Please.
So I am now loading. Yeah. Okay. Inject now. Correct. Push it in. Push it in. Correct. Keep pushing. Keep pushing. Stop there. Stop. Ready for injection? 1 second. Shoot. Actually, the distal dissection, probably we have opposed it. Show it again. The flap has got opposed against the wall. Go to lateral view and show this. I'm just thinking about whether we need to put in another additional stent or just this is enough. What do you think,
Show us the lateral view and then we're going to move on. Show us the lateral, we're going to move on.
Lateral
we'll
view.
try to come back to you if you are able to.
Show the lateral view. By the way, the ACT of the previous patient was 320.
That sounds more reasonable, not 999.
Shaq, that was at the beginning of the procedure where we didn't have, which it was taken within first 20 minutes. Okay, shall we inject again? Show this. I think there is a dissection. Which
you might want to flare the bottom end anteriorly, but we can leave you with that. Yeah.
Okay.
Okay, Shiva, we are going to move on.
Yeah,
you can clear it, and
understand.
if we can come back to you,
Yeah.
we will come back to you. Okay. You
Yeah,
take
sure.
care. Thank you very much. Big applause, please.
Taishak balloon.
Okay. All right.
Taishak balloon
Let's go
20 into
to
4.
Thanks, Shiva and the
let's go to
team.
Qatar now, please.
See, what we did was, am I audible?
Yep.
Okay. We distal end we flared
Loud
with
and clear.
the distal end we flared with the Taishak balloon, which was made by 2 masters in pediatric cardiology. This is the distal end flared with a 20 millimeter into 4 centimeter distally. Show the next picture. This is the proximal end again flared with the same 20 millimeter. Show the previous one, lateral view also. No, not that one. The previous. Yeah, this was the lateral view. Here we previous bus. previous. Yeah. So here we can see that there is a previous. There is the distal end was not opposed, and we were able to see the contrast extending into the dissected flap a little bit above, but we got it totally abolished with a tie-shack balloon. Now we are going for the abdominal aorta. Once again, show that abdominal aortic pictures. Show that abdominal aortic pictures.
If I may
Yes,
comment
yes.
shortly.
Yep, please.
Before this procedure, we were chasing with Pramod's Radamkiewicz artery, and it's perfectly visible in your injection. Where is it? It's exactly when we found it.
I would like to inform people around that Adam Kolesnik is not only a pediatric cardiologist but an anatomist. He identifies every embryonic microscopic vessels on CT scans, on MRIs so efficiently. I admire his skills on anatomy. Get me
Shiva.
Shiva.
Yep.
Shiva, we're going to move back to Sidra now, and so you carry on in case we need you.
Yep.
But we'll go to Sidra next.
Our plan is to stent the abdominal aorta with a bare stent. I will show you later.
Yeah.
Thank you. Shiva, we're going to move on now. We're going to move back to Sidra. Keep going though. We may come back to you. Thank you.
Yeah.
Hey Shiva, we see
Yeah.
you very well.
Can you hear me also,
Yeah.
Zahid?
Just wait.
Yes, I can hear you very
It's
well.
too short. This wire is too short.
See, I'll show you this is the abdominal aorta that we are trying to tackle. If you look at the right renal artery, what we recanalized, there was an aneurysmal segment followed by a total occlusion, which we had put in a 5 millimeter Medtronic Onyx Resolute drug-eluting stent about a year ago, and it is remaining wide open. And just adjacent to that is the narrowing, the beginning of the narrowing. And in the middle of the narrowing, the left renal artery is arising without any ostial narrowing. Show the next lateral view. In that lateral view, if you see, freeze it. The what is protruding down is the renal artery, proximal renal artery is sort of aneurysm that is like a pouch. And then the X3 is the narrowest portion. Now go to the 24th angiogram. Go to 24. This is where we left you. So the distal end of the thoracic aortic covered stent, we flared it to 20 millimeter tie-shack balloon. Next. The proximal end also to 20. We sealed the total aneurysm. So contrary to our original impression that we were planning to use 2 stents, since this 79 millimeter long covered stent is a non-foreshortening stent, it remains at 79, and so it is able to cover and entirely seal off, so with a single stent. Next picture. So then we went for the bare metal stent for the lower part. There can be a contention that the aorta looking so irregular, we can try to put in a covered stent and then transplant both the kidneys. However, we have to remember that it involves 2 renal artery anastomosis to 2 iliac arteries, which basically after a discussion we felt that that is not a great way. And so since the disease is quiescent in this lady for the last 4 years with normal ESR and normal C-reactive protein, we thought addressing it with a bare metal stent and just dealing with the stenosis is enough. Next picture. So here we made an angiogram. We found that the stent is a little bit distal. So push it up, like next picture. So we pushed it marginally. We can also appreciate that there was an area of a dissection in the infrarenal abdominal aorta previously, which we are planning to tack the dissection with this bare metal stent. You can see on the side a dissection flap. So we pushed the stent almost up to the level of renal artery. Next. I think this is the inflation. So this is a 10 into 4 Z-med balloon with a 49 millimeter Zephyr stent. We did not have on shelf a 10 into 6, so we used a 10 into 4. Next, we did the same thing by pushing the balloon proximally. Next, pushing the balloon distally and then got it approximated. So this is at the end of 10 millimeter. We can appreciate the right renal artery with that small aneurysmal sac. Freeze it. Stop. Go back. So the renal artery was reasonably decent. However, the flow is through the struts. It's a hybrid cell design with mid portion is open cell. Next picture. So this is at the end of 10 millimeter. Next picture. So what we decided was we went in to wire the renal artery. Next. So this is the renal artery. It measured about 5 to 6 millimeters. So we put in a Amplat superstiff guide wire. We put in a Mustang 6 millimeter balloon and we inflated the side struts to open the renal artery. Next picture. While we are doing that, we advanced the Tyshak 12 millimeter balloon for the main stent. Next. So this is a 12 millimeter Tyshak balloon for the further little bit of flaring. This is at 2 atmospheres on the top end. Next picture. 2 atmospheres at the bottom end. Next. Next. And this is the final angiogram. Next. So this is, we took out the guide wire and we put in a pigtail. Freeze this when the angiogram is fully filling the aorta. Freeze it. So the renal artery is open. Keep on running forward. So the aorta looks good enough. Run it again. Freeze. 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 Okay. So it looks actually on the just below the right renal artery, small areas it is there are some filling outside the stent. But I don't want to go further and further in that area because the original lumen of that narrowest segment was 4 into 6 millimeter. I have already gone to 12 millimeter. I don't want to inflate further, and then if I tear the aorta, it will create a problem.
I agree with you because in these, yes, I agree with you. In these situations, it gives in very easily once it is opening initially, maybe high pressure opening, but then it seems to give in very easily and sometimes it tears.
Yeah. So this is on a lateral projection.
It looks pretty good to me.
Yeah. So now hemodynamics big. Make the hemodynamics big. This is the proximal and distal. Like the lower sheath is at the level of bifurcation. The upper one is at the proximal end. And we have abolished the gradient totally. And we have sealed the thoracic pseudoneurysm. We have widened the abdominal aortic stenosis. But we have left behind the right renal artery, a small pseudoneurysm as such. And our plan is to do a continued surveillance on this patient with aspirin and Plavix because the drug-eluting stent is there in the right renal artery, and monitor her for activity of aorta arteritis. Actually, originally we were giving prednisolone plus methotrexate. However, 4 years before she got married and the disease activity was not there, so we took away the methotrexate and we kept a very low dose prednisolone at 5 milligram once a day. The renal artery stent angioplasty reduced the need for antihypertensive substantially. While she was previously on close to 5 milligram ramipril, right now she is on 1.25 ramipril. So we are planning to closely do a serial follow-up for a flare-up of the Takayasu activity and also maintain her on dual antiplatelets plus possibly a very small dose maintenance steroids.
Okay, that's fantastic. These are very rare cases. I think you demonstrated very well how to rehabilitate this. I think congratulations again to you, to your team. We really appreciate it, and big hand of applause.
I again thank Varakan, Dr. Shak and all others for giving us this opportunity. And I thank each one of my colleagues, Vishnu, Ashok, all the radiographers, the nurses, intensivists, anesthetists, who are willing to come on a Sunday right in the morning at around 6:30, and they were continuously working. I thank all of them sincerely.
All right,
Thanks to
Shiva.
all of you,
You
sir.
take care of yourself. Have a great Sunday.
My honor and pleasure.
And take care of yourself. Bye-bye now. Thank you. All right. Grab some lunch. The next session starts in 1 minute.